Greetings students, I am Dr. Shubhradev Biswas, Associate Professor of IPGMER. Hope you are all in good health. During these trying times when academics has already taken a backseat, let's hope that learning in you hasn't stopped. Your theory classes have been completed on web platform and now it is time for the clinics. Before I proceed into this discussion, I want you to orient you to the examination pattern that happens and the numbers allotted to each segment of the examination and what is necessary for actually passing the examination. The examination initially will be held in two parts. One is the semester where that is called the internal assessments, and finally when you appear for the MB you appear for the theory and the practical. For the semester also you appear for the theory and practical, and let me tell you how the marks are distributed. In the theory at the MB the total marks is 40 marks. The internal assessment, the theory marks is 10 marks. Though the internal assessment is done on much bigger number of frame, it is actually averaged to 10 marks, and the teachers try to give you good marks provided you are attentive and you have done well in your internal assessment theory examination. Viva is taken at the practical examination, that is done after you have given your MB theory. Of this, theory 40, internal assessment theory 10, and Viva at the final MB practical is 10. It totals to 60 marks, of which you must be getting at least 50% to pass. In the practical examination, other than the Viva, you are also asked to appear for a practical examination totaling 30 marks, and from the semester practical examinations another 10 marks is contributed, and of this total 40 marks you have to score at least 50% to pass. So in first segment you have to score 30 marks and more than 30 marks, and in the second part you have to score more than 40 marks. In the oral practical examination, Viva and long case, short case, instrument X-rays are asked, and this is the marks distribution. For long case you are allotted 15 marks, for short case 10 marks. In the instrument and X-ray part 5 marks is allotted. Now instrument and X-ray, either they are given 2.5 marks each, or for convenience one may be given 3 marks and the other may be given 2 marks, the total of 3 marks or 2 marks, out of which you are evaluated. So you can jolly well understand that long case and short case form the bulk of your oral practical numbers. The Viva numbers, it actually adds to the theory. So if you have done your theory, if your theory is not good, MB theory is not good, you have to be very cautious about this Viva, because if the number is short in the theory of the MB, only the Viva marks will be able to get you out of the tight spot. Now what is a long case? When you appear for the examination, each student will be allotted a long case. Long case is a patient who in ENT who presents with the following clinical conditions. You have to take down the identity of the patient, take a detailed history of the type of problem that he is having. You have to examine the patient, and after you have taken a history and examined the patient, you are required to write down the history, general survey, local examinations, write down a summary, then you have to write down a provisional diagnosis, and after you have submitted this long case to your examiner, the examiner will be asking you questions on the pathophysiology of the disease, different definitions, and he will be asking you at the end that how will you manage this patient. Management includes two parts. One is investigation to confirm the disease, to know the extent of the pathology, and if you are contemplating a surgery, you need to have a anesthetic fitness, for which you need to do some blood examinations, ECG, X-ray, etc. And thereafter comes the definite surgery that is to be done for the individual clinical conditions. The cases are chronic suppurative otitis media with central perforation. Those central perforations are commonly given, or I may be allowed to say are routinely given. Occasionally questions may be asked about the attic perforations and marginal perforations. So while facing questions or chronic suppurative otitis media, you should be smart about each and every aspect of chronic suppurative otitis media, be it tubotympanic or attic ventral. Preauricular sinus, if available, may also be given, but problem with preorbicular sinus is that they are mostly the questions that can be asked about the preauricular sinuses are limited. So usually the preauricular sinus, if available, they are commonly given as short cases. Next major long case from the nose is deviated nasal septum and nasal polyposis. Both antroconal polyp or ethmoidal polyp, depending on the patient admitted, are given for this examination. You will be asked to write down the history, local examination, summary, and provisional diagnosis. Thereafter, you will be asked questions on the pathophysiology of the disease, how to differentiate a antroconal from a ethmoidal polyp, the management investigations, and the management surgeries. Atrophic rhinitis and rhinosporidiosis, again, they are less given, and if the patient is admitted, they are most commonly given as short cases. Chronic tonsillitis is another very popular topic, and you have to identify whether the patient is suffering from a chronic parenchymatous tonsillitis, chronic follicular, or chronic fibroid tonsillitis. All these cases are also given as short cases. If you're given a long case from the ear, you can definitely expect that your short case will be from either the tonsil or DNS and the polyp. So usually from a long case is if given from one system, the short case is usually selected from another system, so that you don't end up answering from the same system in both your long cases and short cases. Here, a student is evaluated on how he is examining the patient. Your teacher is supposed to observe you as you examine the patient, as you handle the patient, and how smart you are in examining the part. You will be asked about you examine the nose, or you will be asked you examine the ear, or you will be asked you examine the throat or inside the mouth. So as you examine, you are going to complete all the examinations related to it. For example, if it is in case of ear, you should ask to examine to do the tuning fork test before you finally write down in your paper only the provisional diagnosis. You present the provisional diagnosis to your examiner. The examiner then will be asking you about the disease, its pathogenesis, then management investigations, and the management surgeries of the clinical condition. Viva is 10 marks that usually adds to your theory. To note, Viva in Viva you may be asked anything from ENT, any part of the ENT. Specially delicate are the anatomy and the physiology parts, because if you fail to answer, the teacher will be very irritated, feeling that you haven't done your anatomy in the previous MDs. You haven't done your physiology in the previous MDs. So you cannot go wrong with the anatomy and physiology of the part he asks about. And then comes the different ENT emergencies. To note, these ENT emergencies may also come as a long case in your theory examinations also. So, as you prepare for the Viva, for the practical, you also should be preparing for the ENT emergencies which may come to you in your theory questions. So, these are the list of the important topics including the emergencies. First two topics, malignant otitis externa and acute necrotizing otitis media. We being teachers, we know that you usually confuse between the two. While malignant otitis externa happens in immunocompromised elderly patients, diabetics, and it is an external ear, that is the disease is happening mostly due to Pseudomonas. The acute necrotitis otitis media is a disease of the children that usually follows a exanthematous fever, and the beta hemolytic streptococcus is the responsible organism. You should be smart about the difference between the two, answering the questions adequately. Foreign body in the ear, the teacher may ask you, spicing up the question by saying that if you have an animate foreign body, how will you manage? The animate foreign body meaning that a live foreign body. Any live foreign body should be killed. How? Or it should be converted to a position where it doesn't move. You can pour ether, you can pour spirit, you can do anything that either stupefies or kills the organism before you can take it out. Why? Because if you are trying to take the foreign body out, the animate foreign body, in its effort to run away from you, will further jump around into the external auditory canal, and it is very uncomfortable for the patient if a live animate foreign body is jumping around in his ears. So you need to kill it before you take it out. Then he will be asking, how do you manage a hygroscopic foreign body? The meaning of hygroscopic foreign body is that any foreign body that absorbs water to swell up. The seeds, for example, the seed, they swell up water, and what happens is that it may get impacted. About 6 millimeter lateral to the tympanic membrane is a bony constriction called isthmus. When that seed was dehydrated, perhaps it has caused the isthmus. But now after absorbing water, if you have used water to syringe the foreign body out, what happens is this seed swells up, and now its diameter is more than the diameter of the external auditory canal at the level of the isthmus, and it becomes impacted. So if you have a hygroscopic foreign body, take care to mention that in cases of hygroscopic foreign body, water should never be used to syringe that foreign body out. Now coming to the syringe, a very common question is, with what you syringe the external auditory canal, with what instrument you use, and also what is the medium that you use to syringe the foreign body out. For medium, you should be answering that it is water at body temperature or at a temperature of 37 degrees centigrade. Why? Because if you give warmer or colder water than 37 degrees centigrade, it is going to stimulate the lateral semicircular canal, precipitating vertigo, nystagmus and sensation of nausea, vomiting in the patient, which is very uncomfortable. Definitely, as a clinician, you should never do something that cause trouble to your patient. You will be asked about the organisms of ASOM. Stages of ASOM are very frequently asked. Secretory otitis media, I find, is a soft corner for all your students because you definitely neglect it and don't study it before your Viva examination. And we teachers know that you have neglected the secretory otitis media and we ask questions from it. Theories of cholesteatoma formation, type of cholesteatoma formation, the types of cholesteatoma, meaning whether it is congenital or acquired, of the acquired whether it is primary and secondary acquired cholesteatoma, and individual pathogenesis of each type of cholesteatoma may be asked. Complications of CSM, if the student is answering well and the teacher is wanting to give him a good marks or maybe an honors marks, then complications of CSM is the favorite topic the teacher asks the student and it is required that you should be learning them well. Occasionally short notes also come from the complications of CSM, and you may also be asked how infection spreads from the middle to the brain, middle ear to the brain. Gradenigo syndrome and the otilia causes are the other popular common topics. Dangerous area of the nose you frequently confuse. It is also given in your semesters and your final examination. Dangerous area of the nose you confuse with dangerous area of the face, and the two regions are completely different. Dangerous area of the nose is actually the roof of the nose, where the olfactory nerve supply taking its dural prolongations. So whenever there is a infection in the roof of the nose and if it spreads to the subdural space in the region of the dural prolongation with the olfactory nerves, the infection easily becomes intracranial and meningitis may be precipitated. Other cause is that anterior to the crista galli in the roof of the nose, there is an emissary vein that drains in the sagittal sinus. And if this vein is having an infective thrombus, it may lead to the thrombosis of the cavernous sinus also. So there is another cause for it being dangerous, and third cause is that roof of the nose is formed by the cribriform plate, which is a very light and delicate structure that may easily fracture due to a minor injury to the head. So these are the three reasons that makes the roof of the nose a dangerous area of the nose, and students should never confuse it with the dangerous area of the face. Granulomatous conditions of the nose, you must be knowing the definitions of the granuloma and the common granulomatous conditions like the rhinoscleromatous, uh, then rhinosporidiosis, etc. Unilateral foul smelling discharge in a child. Uh, Unilateral foul smelling discharge in a child from the nose, and the reason is that these children have got a habit of putting in any and everything inside their body orifice and then they forget. If they has put a foreign body in their nose and they have forgotten, what happens is that foreign body, it remains there, it becomes infected and the child presents with a unilateral foul smelling nasal discharge. So, when the question is that how do you manage a child with a unilateral foul smelling nasal discharge, the examiner is actually asking you how do you manage a child with unilateral foreign body in the nose. Nasal myiasis is maggots inside the nose. You should be knowing about the type of organisms that cause nasal myiasis, which part of the ear they do happen commonly, and how do you manage. Blood supply of the nose is a very popular topic for the question, and also the artery of epistaxis. Sphenopalatine artery is called the artery of epistaxis because it is a major branch from the maxillary artery that supplies the majority part of the nose. So any bleeding that is happening from the nose is most commonly contributed by the sphenopalatine artery. And how to manage the epistaxis. When you write how to manage the epistaxis, you write everything about the management except for what happens when a patient loses blood. That is, you never write or you forget to write about the shock that may happen due to this blood loss. So when you are writing a management of epistaxis other than stopping the bleeding, you should always keep in mind that you are also required to manage a shock, a hypovolemic shock, if it develops in the patient. Walder's ring, adenoid facies are the common questions. Blood supply of the tonsil is a common question. You may also be asked what are the lateral relation of the tonsil. White patch over tonsil is a very popular question that may be asked in your in your viva, but also it may be given as a long question in your theory. Peritonsillar abscess, how to manage. Retropharyngeal abscess, its types and treatment. Stylalgia. Pharyngeal pouch, Killian's dehiscence, Denker's diverticulum. Tracheostomy is something that you should not miss before you appear for your both theory and practical. The indications of tracheostomy, the types of tracheostomy, that is high, mid and low. What are the individual advantages and disadvantages of the individual types of tracheostomy, and their complications are common questions. Foreign body in the esophagus and bronchus, they may be asked in your viva, as also with your instruments of esophagoscope and bronchoscope. The instruments, there will be a tray of instrument, few OPD instruments and few operative instruments. Teacher usually asks you to lift an instrument or may give you a common easy instruments. You should be smart about the OPD instruments at least before you appear for the examinations. Class will be taken on the OPD instruments via this video platform medium, this web medium, and you will be oriented about the questions that may be asked. When you are answering the questions on instruments, you are supposed to identify the instrument and you have to state the use of the instrument. Common OPD instruments, many of them, they have both a diagnostic and therapeutic use. So if you just subclassify them, it is used for diagnostic and purposes like this, this and this, and therapeutic purposes like this, this and this, it is going to help. Then you will be given the X-ray and you will be asked to describe. Before you are asked to describe, occasionally you may be asked to hold it in a proper anatomical position, and then you will be asked to describe. As you are asked to describe, how you describe an X-ray, you have to say it is X-ray of this part of the body, this side, this view. That is, you have to mention the anatomical part, the side of the body, and the view that the X-ray has been taken, showing radio opacification or lucency, having a shape in which part of the X-ray, and then you arrive at the provisional diagnosis saying suggestive of this, this and this. To hold it in a proper anatomical position, you have to write, you have to understand which one is above and which one is below, and then you have to identify which one is right and which one is left. If you see any X-ray, you will be finding R or L impression is present in any one side of the X-ray. So if you find R, it either means the right side or it means that it is the right aspect of the X-ray. And if it is written L, it means the left side, for example left mastoid or right mastoid, or left side of the thorax. You have only one thorax, you don't have a side of a thorax, you have only one thorax, so it is the left side of the thorax, or R for right side of the thorax. And when I say thorax, obviously there is the cardiac apex that point always remains to the left side except for in special rare conditions. These are the common x-rays given and the descriptions. You keep a print of it, you read it up and you present the description like this. First I am reading out. So first it is the x-ray of the skull or of the mastoid. Then you cite the left side. Then you say lateral oblique or Schuyler's view showing sclerotic diploic or pneumatic mastoid. If there is a sclerotic mastoid, occasionally you will find a lytic shadow. In the classes on X-ray, I will be detailing and elaborating these conditions, the different X-rays that will be given for you to you during your examination. And then comes the ENT setup. What you require is this bulb lamp and the head mirror. About the ENT setup and the OPD instruments, our next class will be held very soon.